Hello, good morning, everybody. Welcome to the next episode of the Health System Fix podcast. My name is Dr. Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health system design learner and fixer. Really excited to welcome Dr. Scott Zeller today. He's a true pioneer in emergency psychiatry. He's also the creator of the EmPATH Unit, which is the Emergency Psychiatry Assessment, Treatment, and Healing Unit, which is a model of behavioral health emergency care. He led Project Beta, which is best practices in the evaluation and treatment of agitation. I'm really excited to talk to you, Dr. Zeller. Well,
Thank you very much. It's exciting to be here.
I'd love to learn a little bit about your journey. I'd like to start early. So, can you tell us what was life like growing up?
Well, I grew up in the Midwest, and I did well in school as a young boy. My parents had grown up and said, like, well, the people who get good grades become doctors. So I was told from an early age that I was headed for medical school, and I kind of never thought there was any other ideas that that was what I was going to be. And so, what do you know? I ended up doing it. The journey to psychiatry came a little bit later. I mean, I think when I first went to medical school, I thought I was going to be a pediatrician, and then I found some other things, and maybe I was going to be internal medicine, going to a specialty. And then I did my psych rotation, and I was like, nah, this is it. I think I found my home.
Yeah, medical school is exciting because every time you go to a new rotation, I was thrilled to be there, and it was so exciting. And you think, oh, this is something I would want to do, and then you keep having that experience every few months.
Yeah, no, I loved obstetrics too. I thought that was really cool. And what it was like the happiest thing, where you got to deliver a baby and go, here you go. People were happy. Not everything in medicine is happy. So having some fun things. And actually it's a part of emergency psychiatry that I really like, which is, so a lot of things in psychiatry take weeks, months, years to achieve. But a lot of what we do in emergency psychiatry, you have somebody at the beginning of your shift who looks like they're having the worst day of their lives and just everything's catastrophic. But by the end of your shift, they're shaking your hand and saying, thanks, doc. I'm so much better, and you really changed things. And that makes it worth coming to work every day.
Absolutely. And I think I did my psychiatry residency in Detroit, Michigan, inner city Detroit, ERs, and that training experience sets you up for the rest of your life to, I mean, you can work in any setting and solve problems and de-escalate. And you're right. The amount of benefit you can do for a patient in that setting is huge.
Totally agree. And one thing we always used to boast about was that any resident who'd ever rotated through our psych ER always passed the boards with no problem, because they do go do the oral boards when they used to have that. And somebody would bring up a patient and everybody else would go, oh my God, oh my God. And people from our program would be, I saw 3 of those last week.
I tell some trainees now, sometimes they don't always have an emergency room experience in their training. And I tell them, to understand bipolar disorder and mania, you need to see a patient in mania. And once you've seen one patient in mania, you're set for your life as far as diagnostic things go.
It's pretty pathognomonic, isn't it? There's nothing like acute mania.
And really, I think it helps. I think it helps you triage better. You've done so much innovation work in your career, but let's start with, you were at Alameda Health System for 27 years, right? As their
Yes.
Chief of Emergency Psychiatry Services. Tell me a little bit about what was that experience like?
So I did my residency at UCSF, University of California, San Francisco, and my very first assignment was at San Francisco General Hospital on the inpatient unit there, and it was a 6-month rotation, first postgraduate year. And my supervisor there was a recent grad of the program. She was right out of the program, and she was kind of learning her way along as an attending, and I was certainly learning my way along as an intern. And we managed to hit it off, and so much so that I ended up being godfather for her first child. And she, after that first year, and I was going on into my second and third year, she became a player at the Alameda Health System, and she said, I could really use you here. Do you want to moonlight for me? And I was like, great. And so, because I could use the money. Back in those days, getting an extra $20 was enough to go like, woohoo, this is going to be a great week. And anyway, I started working there as a moonlighter, and I was just like, wow, this is, I found my home. I love this kind of work. And so After I was out of residency, I just became full time there. And after a few years, she went on to bigger and better things. And they asked if I wanted to be in charge. And I said, sure, why not? And it kind of went from there. But what was really nice was that it's a big, huge. When you were talking about Detroit, I'm wondering if you meant Henry Ford. Was that where you
No, I
were?
was at Detroit Medical Center, Sinai Grace, and the VA.
The guy who was our CEO at Alameda for many years went over and became CEO of Henry Ford, and now he's CEO of a huge of the Common Spirit chain. He's also president of the American Hospital Association, so he's really moved his way up. But even before he came in, it was a huge system with so many moving parts, and it was a big safety net hospital in an area of Oakland that was a lot of poverty and a lot of gangs and there was gunshot wounds every day in the regular ER, but we had a dedicated psych ER that was adjacent to the regular ER. And what was really nice about it was that everything was so busy and there were so many spinning plates in the air at the same time that people didn't really notice if I was going to try to innovate. And I know that if I had asked and tried to go through regular channels, I never would have gotten to do anything. So I learned early on in my career that it's a lot easier to ask for forgiveness than it is for permission. And I started just doing that. And I say like, okay, we're going to do it this way from now on. Oh, okay. Nobody challenged that it wasn't through official channels or whatever. And so that led to a lot of really wonderful things that we were able to do to become a direct ambulance receiving site. That wasn't very usual back in those days, 1990s, for a hospital to be able to have a psych ER be a direct receiving site for EMS. But I just said, we're going to do that way from now on. EMS is like, great, why not? I think there was a California law against it, but by the time anybody started enforcing things, we'd already had it ensconced. And it was a wonderful environment. We were seeing 1,500 to 1,800 involuntary patients per month coming in on 72-hour psych holds. In, like I said, worst day of their lives, really bad self-control, all kinds of things. But we were able to make it work, and we were able to make it so that people got their needs met, and it was a safe place and great outcomes. And then it was like, wow, what could we do with this if we really start innovating? And that was what became fun.
I smile also because, what you said was my principle also. I'm going to try something new. And also, if it doesn't work out, me as a team leader, I'm going to own it fully. But at the same time, yeah, let's ask for forgiveness later. But let's try, keep trying new things. And that's a great way to continue to innovate because sometimes in a big system, it just takes so long to get all the right approvals before you can do anything.
No, absolutely. And even in a big system like that, and then there was the whole relationship with the county mental health department, which was a whole separate bureaucracy. And sometimes you just think I know a better way to do it. Let's just start doing it that way and see what happens.
And also the eventual what you are will keep doing may not be the same as you initially thought, but you will try a few different things to get to the best version of it.
Exactly. Absolutely. And you were kind enough to mention the Project Beta work that we did with the best practices and evaluation and treatment of agitation. That was a project that I led when I was president of the American Association for Emergency Psychiatry, like 15 years ago. I was saying, well, having this presidency, I really like to take on a project. And I don't think there's really good guidelines for agitation out there. And I was amazed how many colleagues were interested in being a part of that project. And we had over 40 people from around the country. We worked on it for 18 months. And we published it as a 6-article special section of an emergency medicine journal because we figured those are going to be the people who see agitation more than the average private practice psychiatrist does, right? And so we published in the emergency medicine journal. And to this day, they're still the most downloaded and most cited articles in that journal's history, which is pretty cool. They love us there. But what's even better about that is that I think that really helped us to change the way that agitation and aggression is approached worldwide. It really started to recognize and get across that de-escalation is your best tool, not tackle and forcibly inject, that you're going to actually get better outcomes. You would not believe when we first came out with the beta guidelines, how many people would get up and like old hand ER docs would get up in the middle of a meeting and start screaming at me that what the hell did I think I was talking about? These people are dangerous. You need to put them in 5-point restraints and heavily sedate them until they're unconscious. That's the only way we'll be safe. And that sounds even bizarre today that there would be people thinking that. I mean, everybody includes de-escalation in their work now, but I think Project Beta really did that. But going to the whole point of like what we do with empath and all that, everything for empath, other than the idea of the emergency psychiatry, which was already kind of ensconced from working at Alameda, everything that was innovative and everything we did that improved the patient experience and improved the outcomes, that all had its roots in Project Beta. All the things we learned there. What are the kind of things that make people agitated, kind of make things frustrated, make people angry? How can we avoid that? How can we mitigate that? And that went a lot into the design of Empath.
I think that's interesting because I think the old way of treating agitation was a lot like what sometimes medicine and healthcare does, which is just wait till the problem becomes really bad before doing anything about it. Whereas I think if you talk about de-escalation, that's talking about having an awareness before things are really bad. Can you talk a little bit about how that view changed your thinking for empath and also Project Beta?
That is such a great pickup and such a great point on your part that so much of what we had done in acute care psychiatry was reactive rather than proactive. And the greatest example, and unfortunately, I think this still goes on too much in systems that are still patient goes to the ER sends a fax to the inpatient psych facility 50 miles away. Then they send another fax because they didn't get the first one. And then they accept the patient and you transport the patient there and the patient arrives at like 8 o'clock at night. They call up the attending psychiatrist who gives them some admit orders and some PRNs. So that whole first 12 hours or so that patient is in the psych hospital, the only meds they have are as needed. And so the only time the nursing staff is giving those PRNs, those as needed meds, is when somebody is agitated or aggressive or floridly psychotic. And that's waiting too long. Nobody's treating ahead of time. One of there's multiple pillars that the empath model is built on. And one of the most important ones is like we've talked about the environment. You have a therapeutic environment, but another one that I think maybe because so many people are interested in the environment concept that maybe not as much attention is paid to this part, but I think it's really the biggest part for why empath units are successful. It's prioritizing the care and initiation of a treatment plan so that we're wanting patients to be seen within minutes after arrival and started on a treatment plan. And if meds are indicated, starting them as regular meds and not waiting and for somebody to judge whether or not it's time to give them. We're going to prevent problems by starting people on appropriate meds right away, not as PRNs. And that's a different way of doing things. The way that I just described, which is they're in the ER for 36 hours, then they're transferred for 8 hours, and then it's another 12 hours, and then finally see the doc the following day. There's 72 hours sometimes before anybody's had a real evaluation and a treatment plan started. If we move that all to the front, which is the biggest part of empath, we get great, great outcomes. How can you treat some people so fast in empath? It's because we don't waste time. We don't have those delays.
And that's really about when we talk about let's meet the patient where they're at. Right? It is such a core concept of a patient in the past would walk in and wait 24 plus hours to get any reasonable treatment and even evaluation, let alone treatment, not even knowing what's going on with me. And versus now meeting them, their need is so high that let's prevent them from getting worse while they're with us already. I'm very curious about as you started thinking through building the empath model, what were the things that you were thinking, this is working well in our system, and this thing I definitely don't want to replicate? Do you remember thinking through the system design a little bit? And can you tell me some ideas around that?
So one of the real ways that the whole empath really had its beginnings was this was right after we had just published Project Beta, and I kept seeing these national news stories, like say like on NBC News, where it would be some reporter live at a regular ER somewhere. Oh, we're at Mass General Hospital's ER here, and there's a dozen psych patients that are waiting for beds, and they're taking up half the available beds in the ER, and other patients can't come in. And then they'd say, all these patients are waiting to be transferred to an inpatient bed. So clearly, the only solution is we need to build more inpatient beds. Back to you. And I would hear that, and I'd know we had just done with beta and what we were doing at Alameda and saying like, that's not the answer. We don't have when somebody comes into the ER with an asthma attack and they're short of breath, we don't say, oh, we've got a bed in the back for you and we're going to find you an asthma hospital and it should only be a day or two, keep breathing. But that's what we do with psych patients. That's the answer is not build more inpatient beds. That's just kicking the can down the road because we'll fill up those beds and then what are you going to do? We need to change the process at the front. Why are psych emergencies the only medical emergency that our default treatment is find them a bed? That doesn't make any sense at all. So what I really wanted to do was change that and tell them what we'd learned at places like Alameda and other places doing emergency psychiatry around the country, which is see a patient, start treatment right away. Guess what? The majority of them aren't going to need inpatient because you're going to take care of the problem. But from what we'd learned with beta and what I'd learned kind of looking around and visiting other places around the country, around the world, actually, was that it would be better to have an environment that was actually conducive to healing. We know that the regular ER environment is frightening and claustrophobic and can make behavioral emergency patients' symptoms worse. So the first thing that I did was I said, I've got to prove that emergency psychiatry actually works. So I did something that ended up becoming known as the Alameda Model Study, which we showed what we were doing in Alameda and how there was no such thing as psych patient boarding in ERs in our county because we took everybody as soon as they were medically stable and we had a psychiatrist evaluate them immediately and start them on treatment. And so not only was there no boarding, we were discharging over 75% of the patients we saw. And I sent that into an emergency medicine journal that I knew the editor pretty well, and I hadn't heard from him for a few weeks. And I said, "Hey, what do you think? Are you going to publish this study that I did?" And he said, "I can't publish this. There's no way this is true. This is not possible." And I said, "No, I'll show you all my data. I'll show you all my everything that I got." And he goes, "No, okay. If it's really true, I'll publish it, but it doesn't seem to make sense. All these people needed inpatient. How can you possibly get 75% of them better in home in less than a day?" So anyway, that got a lot of attention when it got published, and people started going like, "Wow, this changes everything." And then so I was approached by some different hospitals saying, "Hey, can you help us do this from scratch?" And I was like, wow, if I have this ability to do this from scratch, could I incorporate everything we learned from Project Beta on how not to make people angry and not to make them frustrated, make them feel supported and make them feel like this is a place of healing. And then take the other things I figured out, which is people respond to a nice environment. If we make this into a non-coercive environment and non-threatening environment, will that make it better? We can make it nice, make people feel like they're in the lobby of a nice hotel instead of in a maximum security prison. And if we do that, what are kind of outcomes we going to get? So fortunate enough, a couple of hospitals gave me a blank slate and said, take off. And we were able to create some wonderful programs. And then it just kind of snowballed from there.
Several years, I built several mental health programs. One of the things I saw was we are also setting up our frontline healthcare workers to not do great work because they are not set up with either the resources or the training or the having the empowerment to do this aggressive, let's get this things treatment started. How do you think about designing the work part for the healthcare worker within the empath model?
Well, I think that there's no greater resource that you have than your staff. There's things that we do with Empath that I think are a bit novel for people working at that emergency level of care. For one is we always really clearly state everybody's in this together on the staff and we don't have a hierarchy here. And I don't want to ever hear you say that's not in my job description because everything's in your job description. And me as a doctor, if something spills and I need to grab a mop and get it up, then I'm going to do it because I'm the one who has the ability to do it. And you can't have this, I'm the doctor, I'm too important or anything, because everybody needs to work together to help these people who, like I said, are having maybe the worst day of their lives. And how can we help get them through that and maybe have a positive outcome by the end of the day? And that really requires everybody wearing a lot of hats and feeling like we're all part of a team. And there's not like I'm in charge and you're going to do what I say, but more like, hey, let's all work together and let's figure this all out. And then let's do it in an environment where we feel it's very optimistic and uplifting. And instead of that kind of morbid usual walls of the county hospital, kind of off greenish blue, that we're gonna have nice murals and hopefully windows and high ceilings and everything open where people are able to move about freely and nobody's saying, "Get back in there or I'm calling security," but rather when you have acute mania, you feel better if you're able to pace around a bit and it helps you to relax a bit. That's okay here. You can't pace the halls of an ER, but you can pace in an empath unit. And everything's open. People are able to serve themselves beverages and snacks. They don't ever have to beg a staff member for anything. And that makes it better for the staff as well, where they feel like they're really there to be involved in the patient's improvement and not being there to be a jailer or to say no or to like you must do this, but rather how can I help you get through this day? And so there's even parts of empath units where we always have some tables where people can sit and eat the snack or the beverage that they've gotten for themselves. But also we have like board games or dominoes or cards, and we encourage the staff to actually start games. So how many jobs pay you to play dominoes? And we can have like our psych techs start a game with three of our patients, and everybody kind of relaxes. They have a little fun, and when they're doing that, they're able to talk a little more. They're a little distracted. Maybe they can talk a little bit more about what's going on, the same way we all do when we're playing a game with our friends. And that allows people to not feel like they're on, under scrutiny, but maybe like, "Oh, well, gosh, I did have a you wouldn't believe what happened to me this morning," kind of things. And then they're sharing it. And so it just kind of changed the whole idea from making this very clinical, very coercive, very, like, shameful even if you'd think, environment into one that's of optimism and where the staff feel like they're really integrated. And I think that leads to staff feeling like this is the best job they ever had and not feeling burnt out because every day they have positive things happen. Every day is different than the day before, and they're encouraged to do things that are fun and positive as opposed to, "Let's put that person in restraints."
Yes, the concept that's resonating is really, I think there's at the core, we need to have like basic human respect for our patient and for our team. And which is often both of those are missing in many health settings. I think you have a no exclusion policy.
It's as much as possibly no exclusion. Yeah, I mean, we're not gonna take somebody who's actively hemorrhaging blood or who's unconscious or, is have active chest pain or is in a seizure. So, clearly, anybody with an acute medical emergency is excluded, but other than that, we wanna have about 0 exclusions, and it doesn't always work, but that is our goal, and the reason being is we know that our environment is much more conducive to healing. It's a much more therapeutic environment for folks, so why keep them in the regular ER any longer than they have to be? It's better, and then that opens up beds in the ER for people coming in with broken arms and chest pain and all those other things, and so it's a win for the ER and it's a win for our patients.
A learning I had building some of the programs was we would start with this extremely well thought through inclusion criteria, right? And a year in, I would realize, oh, we're actually excluding people by using this inclusion criteria. It's actually not serving the purpose we thought it would serve. So having relatively open, no exclusion within reason is probably the right way to go.
Yeah, and even things that sometimes people would say, "Oh, we can't take those patients," and it's like, "Well, why don't you say if the person has this, we'll do it on a case by case?" Because sometimes maybe it's okay, 'cause there's some places that will say, "Well, we can't take any people with intellectual disabilities." Well, maybe sometimes it makes sense for them to be here. Certainly better than for it to be in restraints in a small little cubicle in the ER with a sitter, and they don't understand where they are or who these people are and what's going on, and so they're screaming and fighting with restraints. Well, that's understandable because they don't really it's a confusing situation for them, let's say. Move them into the empath unit where everybody's like, "Oh, no, they're ID, they're not psych." No, no, they're having a bad day, and we can allow them to move around and not feel frightened, and they can make a friend with one of our team or our peer support specialists, and all of a sudden, they're not screaming, yelling, and combative. They're doing great, and then we can call up the group home and say, "Hey, for the last 12 hours, they've been fantastic. Let me give them the phone. They wanna ask to come home." And what a difference that is. So that's case by case.
Right. I've done a lot of work with kids who have intellectual disabilities, but also adults. And oftentimes for adults, they don't have somebody who owns the care between mental health, these patient or neurology patients almost kind of bouncing around, but nobody having full ownership of how this care needs to be done. And this inclusion, I think it may work really well for many patients who have intellectual disabilities. As you're thinking through designing the empath unit, did you go in places for inspiration outside of healthcare? Curious about that. Where did you go and how did you think about getting input which is different than your typical healthcare inspiration?
So one of the first things was, so I have multiple myeloma, bone marrow cancer, lymphoma. And I've been on chemotherapy for 14 years now, which is great. And I'm in a nice deep remission. And I go in and I get chemo twice a month. And when I go into the chemo infusion suite, they have these lovely, big, comfy recliners that I sit in. And it's like, wow, this is, if I'm going to get medical treatment, this is a pretty sweet way to get it. I'm not sitting in a chair. I'm not in some bed where I'm kind of horizontal and hospital beds. Those aren't, nobody, no hotel advertises we have beds just like hospitals, they're not very inviting or comfy beds. But instead, like a big recliner, which is easy to get up and out of and move around, but also when you want to, it's very comfy and relaxing. I saw that in my chemo infusion, and I was like, boy, these would be much better for, like spending 10 hours in a psych environment than what we have now, which is basically really stiff chairs or sometimes even just a blanket and people are sitting on the floor in a lot of these places. What if we started rooming in more of these? And so that just came accidentally from my own experience as a patient myself, thinking I would prefer to be in this, and I bet a lot of other people would too, especially compared to the alternatives that we have. And that's the thing I always want to stress about empath, because sometimes I go to things where I meet with people in the architecture world and the healthcare design world, and they're saying like, why couldn't we do it like this and this and this? And I always have to bring them back to, remember, empath is replacing people being strapped to a gurney in a back hallway of an ER. So when you start talking about all these other kind of things, go back to what it is right now, what the status quo is. And we're improving on that. So these are lovely ideas, but you're talking about changing the project from a $2 million remodel to $20 million. And maybe the hospital doesn't have that money or want to commit to that. But if we could do it for 2 million and we make life really, really better for people, why not do that? So that's at least where I got the idea for the recliners, and there was other programs that were starting to use them as well. So it wasn't like it was my invention. But the other thing was I travel a lot in my work, and the lobbies of hotels, sometimes they can be really nice, but I think more than anything, being nice is being inviting and feeling comfortable. So that when you go in there, you're maybe you've checked into a hotel and it's 11 a.m. They're like, I'm sorry, sir, your room's not going to be ready for 3 hours, and you feel free to sit in the lobby here until then. Maybe you can order a cup of tea or something. And if you're in that place and you feel comfortable, and all of a sudden you look up and, oh, sure, your room's ready, and you've been comfortable that whole time and you're not angry and it's nice. What are those things that are involved in that? What it creates that kind of therapeutic environment where it's a comfy chair or feeling like things are nice, or it's people are attentive and thoughtful and kind to you and all these kind of things. Why can't we make our psychiatric emergency setting the way you feel in a really nice hotel lobby? And so I think I got a lot from that, and just seeing how they're done. The things in the really nice hotel lobbies have high ceilings, they have natural light from windows, and they have comfortable chairs. If you put those three things together, that's kind of what we think the empath environment should be.
It smells nice. It's like cool. It's not
Yeah.
too hot. One of the areas of healthcare, and especially within the mental health space, I see which the big gaps is in dementia care. So I've been working for an organization, incredible opportunities, did a lot of program build, but I'm now working on starting something of my own, building a comprehensive dementia care program where a patient or somebody from a PCP team could refer them. And the vision is to let's do a comprehensive evaluation in the clinic, in the home. Let's have a real partnership with the PCP where they know what's going on. And then you're really doing like extreme hand holding of the patient and their caregiver, which is just a giant gap in our health system. As I'm thinking through building the program, I don't know if you have thoughts and um, suggestions of how I should think about getting this going.
It's a great idea. And having had experience with relatives going through serious, severe dementia. I completely understand where you're going. What I remember most of all with the relatives that were going through this and when we would go visit them is how much familiarity helps them out. Things that they're naturally familiar with helps them kind of to regulate because you know that the last thing to go is the long-term memory. And you're already dealing with the loss of the short-term memory and all those things. Anything that's very reminds them of being at home, let's say. And so things like couches. We don't have couches in hospitals or things like that, but everybody's house has a couch, right? So you have a couch and they're kind of like, oh, I'm going to sit there and watch the television because I always sat on the couch at home and watched television. They're not saying that obviously, but somewhere in the back of their head is like, this is a comfy place. This is home-like, and this makes me feel comfortable and not afraid and not confused, but that this is something I've done my whole life, and so I can do this now. So making it seem much more home-like, the more you do that, I think, the more people will relax. And I think when people are relaxed, it's a lot easier for us to collaborate with them to good outcomes.
Yeah, that's great. Incredibly helpful. I'm trying to keep my vision as close to possible to the patient experience and the healthcare team experience of having a really good outcome, or at least having space to do good effort, and then hopefully the outcome would be great. Over the years, how did you invest in your own leadership growth?
I probably should have. I probably would have been a much better leader if I spent some time on that. Sometimes I've been like a bull in a china shop, just like I'm trying to make this happen. People don't quite understand. Like I said, asking for forgiveness rather than permission. I don't know that I ever did any specifics in that, but I was blessed with having great role models and great mentors that I was able to use in what I learned from them and try to mimic them and try to be the best of what I saw in those people. And so there was nothing formal, but I probably would have benefited from something formal. It was just we were too busy doing other things. And I don't know there was as much coaching and world of things like that we've seen in the last few years, but I did have some terrific teachers and mentors.
Do you think, as I think about the model of care, I'm also thinking similarly as you did about let's build a program that you can actually study and publish on. What did that help you do? Did that help you grow the program more, or did it help you get authenticity? What was the goal behind doing that piece?
I don't know why it dawned on me at that point, like I told you in the story earlier, that I really needed to get data and prove that my idea worked as opposed to everything else I was doing. But I just kind of recognized because I was talking to these people and being in meetings with the people about what are we going to do with all these psych patients stuck in ERs? And I was trying to point out to them, the idea of a PES or a psych ER. And they were just looking at me like I was talking to them about a fish riding a bicycle. I don't know what it is you're talking about. Doesn't make any sense. I'm going to talk to this person now instead. And so I realized that I had to do something to actually create it. And I was fortunate enough, again, kind of behind the scenes and under the radar, so to speak, to create that whole study. And I got 5 other hospitals to participate in it, and everything was just me calling up the ER director of that other hospital. Hey, can you take this data for a month for us? Sure, no problem. So that worked out. I think what the whole thing was that we're in a world of medicine for the last 10, 15 years where the concept of something being evidence-based is really important. The ability to demonstrate data that supports your concept is really important. And you can give somebody an incredibly wonderful idea, and they're not going to do anything about it until you can able to back it up with evidence. And so I think that setting up what we were doing so that we could report on it was really important. Like I was saying before, doing that Alameda model study really led to everything that became empath. And then once we had empath, we were able to demonstrate great data and other people did studies. I think the only thing that I wish there was more of, I wish there was more people doing empath data studies. The only issue with it is that the parts of the staff who are working in the hospitals that want to create and actually create empath units are wonderful, hardworking, forward-thinking clinical types, and they're not researchers. So when they're doing things, they aren't also putting together data and putting something into a format they can publish. I wish we did because I'd love to have more data out there because everyone I talk to anecdotally says, "Oh, we're getting these wonderful outcomes." And saying like, "Well, maybe you'd wanna publish that." "Yeah, well, let me see if I can find somebody who, maybe second-year resident would be interested in doing that. They're all very, very busy people, and maybe they're not as excited about publishing studies as somebody like me or you might be. But that's kind of the only thing I wish that we could see more of, because there is this wonderful world of emergency psychiatry that is just a font of data. If anybody wants to kind of just start trying to collect it, right, and interpret it, but everybody is also, hey, I just finished a 12-hour shift and I saw 33 patients. Where am I supposed to be doing this research?
That's true. Coming to the last question for today, what is the most exciting or challenging problem you're working on today?
I mean, the challenging is the biggest part. It's exciting because of what we think we might be able to do, but it's really challenging, and that is overcoming state regulations and state laws to get better emergency psychiatry solutions out there. Because the whole system for the last 50 years or so has been predicated on, if you come to a hospital ER and you've got acute psych symptoms, you are going to be transferred to a inpatient psychiatric hospital bed. It's just been like that. So we've been fortunate enough to open the EmPATH unit. I mean, there's over 60 EmPATH units operating now in the US. They're also in 4 other countries. And by next year, we're going to have over 100 operating in the US, which is a wonderful thing since the first EmPATH unit only opened 10 years ago. And that's a nice amount of growth. However, the ideas and the energy and the people wanting to do it are developing faster than the state laws and the state regulations can catch up to it. So there's a lot of times where somebody's got a whole EmPATH unit ready to go, and the state regulators say, like, we don't know what this is, and this is not in our law, so you can't do it. And it's like, what? You're talking about something where we're going to save millions of Medicaid dollars per year. We're going to have better outcomes, fewer workplace injuries, fewer restraints, all these kind of wonderful things. And you say we can't do it because it's not in the laws. So the biggest challenge right now has been to work with some colleagues and try to really approach state legislators, state executive branches, get just people to collaborate so that we can change laws. For example, there's a wonderful state legislator in Atlanta she's got the Georgia EmPATH bill that's in this current session that she's trying to get in so that they will permit more EmPATH units in the state. We're trying to do things in California where I'm based, which are still, I mean, we're going to have 20 EmPATH units in California by next summer, and yet it still doesn't exist in the state law. So it's confusing to the state regulators all the time. How do we overcome all these? It's wonderful to innovate, but sometimes the system isn't ready for you to innovate. So that's the biggest challenge.
As you rightly said, as an innovator, you have to think through the long-term financial sustainability of the model. Otherwise, it kind of goes away, right?
The other problem with that is that we have everything set up so it's financially sustainable and all these kind of things, and people working in the hospital still can't quite change from what the things they've done traditionally. And so they'll say, like, well, I know this person needs to be admitted, so why waste time sending them to EmPATH? And it's like, well, no, I can give you 10 reasons why that's a good idea. Instead of sitting in the ER for 16 hours waiting for that bed, why don't you move them over? And even if they do need to be admitted, then they're going to hit the ground running. They'll have a day of treatment under their belt. And some of those folks you think need to get admitted are going to get better. And they're going to surprise you and they're going to be able to go home. Because what I know as an emergency psychiatrist is sometimes the people coming in who look like they're in the worst shape actually are the ones who get better the most quickly. So why would you ever try to find a way not to have people go to EmPATH? But some are still locked into that. And when that happens, you have a half-empty EmPATH unit, and that's not going to be sustainable. So we want to get everybody moved over as quickly as possible out of the ER and stop trying to find reasons not to go.
And I've actually seen the quality of inpatient care in general being poorer recently in the last several years. I think in general, what you think about inpatient, somebody who's really sick goes and gets very intensive care for a week, hopefully at least, right? So there are patients who may benefit from that longer term stay in an inpatient unit, but there's so many other patients in that area where EmPATH would possibly be a better solution for them. Thank you, Dr. Zeller. It's an incredible opportunity to speak to you and to learn about your journey and about innovation within the healthcare space, within the organization, and also outside and growing from that. So I appreciate you joining us today.
It was absolutely my pleasure. Really fun. You're a great interviewer. So thank you for having me on.
I appreciate it. Okay, you take care.